سلطان.
الو، السلام عليكم.
وعليكم السلام.
وعليكم.
We can start.
Yes.
واضح.
واضح.
طيب، بسم الله الرحمن الرحيم. I am Sultan Amro, cardiac surgery resident from King Fahd Cardiac Center in Riyadh. Today, inshallah, I'll talk about surgery for cardiac arrhythmias. We'll go, inshallah, through a small introduction. Then we'll talk about ablation technique and surgical technique, then indication for surgical intervention. Cardiac arrhythmias management was limited to pharmacologic therapy, and the interventional therapies have rapidly evolved over the past 3 decades. In 1970s, surgical intervention was described for treatment of cardiac arrhythmias, with the first resection of atrial focus was reported in 1973. The first catheter-based ablation procedure was reported in 1981. Many procedures were introduced for treatment of cardiac arrhythmias evolved until we reach the current clinically accepted procedures. So some of the procedures, we'll mention some of procedures was started or tried for treatment of atrial fibrillation or cardiac arrhythmias. One of them is the left atrial isolation procedure. It was the first surgical procedure designed specifically to eliminate atrial fibrillation. Its idea is to confine atrial fibrillation to the left atrium and restore sinus rhythm in other areas. So the right atrium and right ventricle to contract in synchrony, providing normal right side cardiac output. But it did not eliminate the thromboembolic risk. So this procedure never achieved clinical acceptance and was only performed in a single patient. Then catheter ablation of the atrioventricular nodal His atrioventricular node His bundle complex. It was to control the irregular cardiac rhythm associated with refractory supraventricular arrhythmias, but remain a common treatment for medically refractory atrial fibrillation, despite the AV contraction remain desynchronized. So that's keep compromising the cardiac hemodynamics and require permanent pacemaker implantation to restore normal ventricular rate, and the risk of thromboembolism persists. The corridor procedure is to isolate a strip of atrial septum harboring both the sinus SA node and AV node, allowing the SA node to drive both ventricles. So was abandoned because no effect on hemodynamic compromise. So as the atria were isolated from their respective ventricle, and AV synchrony was prevented. Also, the risk of thromboembolism persists because both atria either remained in atrial fibrillation. The atrial transection procedure is the first procedure that attempts to terminate rather than simply isolate or confine atrial fibrillation to the atria. Is a single long incision around both atria and down to the septum, effectively prevented atrial fibrillation or atrial flutter in animals, but not clinically when applied to human. It led to foundation of the development of Cox-Maze procedure. So why atrial fibrillation? Atrial fibrillation is the most common arrhythmia worldwide, and it's associated with significant mortality and morbidity. Manifestation of atrial fibrillation is palpitation, which causes discomfort and anxiety for the patient. Loss of atrioventricular synchrony, which compromise cardiac hemodynamic, resulting in various degrees of ventricular dysfunction, and stages of blood flow in the left atrium, which is a thromboembolism and stroke risk. Non-pharmacological treatment approaches developed as a result of the inefficacy and the side effect of antiarrhythmic drug used for atrial fibrillation. Initial attempt aimed to provide rate control failed to address the detrimental hemodynamic and thromboembolic manifestation of atrial fibrillation. So the early attempt at finding a surgical treatment culminate in the introduction of the Maze procedure in 1987, which became the surgical gold standard for atrial fibrillation. For successful ablation, it must reliably procedure by directional conduction block across the line of ablation, and the ablation device must be safe to limit the excessive or inadequate ablation and potential injuries to surrounding vital cardiac structures. The ablation device also should make the atrial fibrillation surgery simpler and faster. So many devices manufactured for ablation utilizing different energy sources as microwave, laser, ultrasound energy, and the most common or nowadays is the only or most used ablation device is radio frequency, either unipolar or bipolar, or the other devices that depend on the effect of freezing of tissue, the cryo ablation. For radio frequency ablation, it's the delivery of sinusoidal alternating current between the catheter tip and the endocardial surface, and large grounding pad on the skin. So the principal method of tissue injury is thermal. To achieve irreversible tissue injury with radiofrequency ablation, the frequency should be between 350 and 700 kilohertz, and the tissue temperature should be around 52, between 50 to 60 or 58. Lesion size is proportional to the tissue temperature, the size of ablation electrodes, the current and voltage, and the duration of ablation. Endocardial ablation lesions are limited So some intramural and epicardial foci and arrhythmia circuit may not be reachable with standard ablation. If subendocardial tissue temperature exceed 100 degrees, steam may form within the tissue, resulting in crater formation. Ablation catheter have thermistor to avoid that. Have thermistor that allows for automatic adjustment of power output to achieve preset temperature at the electrode tip tissue interface. And the other measures taken to prevent that is cooling of the ablation catheter tip with saline irrigation, that to prevent a rise in impedance and allow for more energy delivery deep into the tissue. These catheters continue to use radio frequency as an energy source with maximization of power delivery, resulting in deeper lesion with a great volume than with the standard radio frequency. So the other thing is to increase the effect of ablation is to increase the catheter tip, to increase lesion size and depth, can increase the catheter tip or electrode tissue interface. But the limitation of larger catheter tip is larger interface area makes difficult to regulate power delivery and achieve even temperature. Disadvantage of radiofrequency ablation, that it causes irreversible tissue injury that results in permanent damage to normal conduction system if used to create lesion in close proximity to the AV node. The other thing, is the risk of extracardiac tissue injury resulting in potentially high morbid complications such as pulmonary vein stenosis, phrenic nerve paralysis, and atrioesophageal fistula. The other most common used ablation technique is the cryo ablation, which is dependent on pumping refrigerant to the electrode tip, where it's transformed from liquid to gas phase. So it absorbs heat energy from the tissue in contact with the tip. So it's destroyed myocardial tissue by freezing using either nitrous or nitrous oxide or argon. At 1 atmosphere pressure, nitrous oxide is cooling tissue to around 90 degrees, but argon has minimal temperature of minus 185. So in cryoablation, the lesion size depends on the temperature of the probe and thermal conductivity and temperature of the tissue. So preserving the myocardia, it's used to preserving the myocardial fibrous skeleton and collagen structure, and it is the safest energy source available for ablation. The disadvantage of cryoablation, intimal hyperplasia and coronary stenosis. It's relatively long time required to create lesion. It needs each lesion 1 to 3 minutes. Difficult in creating lesion on beating heart, and it may coagulate blood, which risks the patient on thromboembolic event if used in beating heart. Now we talk about surgical technique for atrial fibrillation. Is the most common is Cox-Maze procedure. Cox-Maze procedure clinically introduced in 1987. It's interrupt any and all macro recurrent circuit, successfully restored both atrioventricular synchrony and sinus rhythm, potentially reduce the risk of thromboembolism and stroke. The concept of Cox-Maze procedure is creating an array surgical incisions across both the right and left atria. These incisions were replaced so the SA node could still direct propagation to the sinus of the sinus impulse through both atria. It was modified because of the problem with the late chronotropic incompetence and high incidence of pacemaker implantation. So modification of Cox-Maze procedures passed through many modifications. This was the Cox-Maze 3 procedure, which is named or usually known as cut and sew maze, became the gold standard for the surgical treatment of atrial fibrillation, with 97% of patients at late follow-up were free of symptomatic atrial fibrillation, but it was technically difficult and required a more lengthy period of aortic cross clamping. So atrial fibrillation surgery was revolutionized by the introduction of a variety of ablation devices that have been used to replace the surgical incision on the atria. This has made atrial fibrillation much simpler to perform. With the presence of ablation technology, surgery can be performed with low morbidity, low mortality, and often through less invasive approaches. So the Cox-Maze 4 principle, which is replacing the surgical incisions of Cox-Maze 3 with lines of ablation using ablation technique, significantly shortened the operation time while maintaining a high success rate, and performed on cardiopulmonary bypass, either central or femoral peripheral cannulation, either through median sternotomy or right mini thoracotomies. The lesion of Cox-Maze 4 can be subgrouped into pulmonary vein isolation lesions and left atrial lesions, right atrial lesions. Different lesions can be performed in different situations. Some lesions can be done epicardial, the other can be done endocardial, either beating or with arrested heart, and with the use of different devices, unipolar, bipolar, and bipolar clamp. So the right atrial lesion should be completed down to the tricuspid annulus. It's one lesion between the IVC and SVC, and then lesion here beside the septum and down to the tricuspid annulus. Pulmonary veins are individually isolated, either isolation with each the right and left separately, or isolation with connected lesion, or box isolation of all pulmonary veins. Left side lesions connecting pulmonary veins isolation, and then ablation is performed down toward the mitral annulus. So here the pulmonary vein isolation lesions. The left side lesions is to connect the lesions between the pulmonary vein isolation lesions, and one lesion is going toward the left atrial appendage. Then one lesion is going to the mitral annulus. He should be careful for the circumflex heart. The left atrial appendage is amputated and ablation performed through the amputated left atrial appendage into one of the pulmonary vein isolation lesions. So, compared to Cox-Maze 3 procedure, Cox-Maze 4 procedure significantly shortened the cross-clamp time, about 40 to 50 minutes, shortening time less than Cox-Maze 3, and showed comparable result of freedom of atrial fibrillation can be reached in some studies up to 90%. Even acceptable results of freedom from antiarrhythmic drugs up to 80% in some population, and it's very successful in reducing the incidence of stroke and discontinuing anticoagulants. The right mini thoracotomy approach for Cox-Maze 4 procedure is equally effective at restoring sinus rhythm and significantly decrease major complication, operative mortality, and hospital length stay when compared to sternotomy approach. The other procedure or partial ablation of for atrial fibrillation is the left atrial procedure. Left atrial lesions is completed if the ablation of the coronary sinus in line with the endocardial lesion, isolate the entire posterior left atrium and connect the lesion to mitral valve annulus, then remove the left atrial appendage. The advantage, if missing the left atrial isthmus lesion result in significantly higher incidence of recurrent atrial fibrillation in patients with permanent atrial fibrillation. And one advantage of avoiding right atrial lesion is the potentially lower rate of post-operative pacemaker implantation or heart block. So, comparing left atrial lesion with Cox-Maze, the atrial fibrillation can originate from the right atrium in 10 to 30% of cases, but the other majority is originated from left atrium. The biatrial lesion set result in significantly higher late freedom of from atrial fibrillation compared with left atrial lesion set alone. Comparing the left atrial lesions procedure with the pulmonary vein isolation alone, versus left atrial lesion include ablation of the left atrial isthmus. Normal sinus rhythm at 2-year follow-up was only seen in 20% in pulmonary vein isolation group versus 57% in other group. Even isolating the entire posterior of left atrium significantly improved drug-free freedom from atrial fibrillation at 6 months, 57 in pulmonary isolation and 79 in left atrial procedure compared with pulmonary vein isolation alone. So the last one is pulmonary vein isolation. The concept of pulmonary vein isolation, it is pulmonary vein isolation procedure is attractive therapeutic strategy because can be done without cardiopulmonary bypass, approachable with minimal invasive technique, either thoracoscopy or small incision, and easily and quick added to other cardiac surgery procedure with less invasive technique. The triggers for paroxysmal atrial fibrillation originate from pulmonary veins in 70% of cases. And the most common approach for treatment of lone AF used and endoscopic or port-based approaches. So, in pulmonary vein isolation procedure, a bipolar radiofrequency clamp are favored to use, but other can be used. And the pulmonary vein can be isolated separately or in box region. It is critical to document pacing threshold from pulmonary veins before isolation, and then conduction block is confirmed with pacing after ablation. So the procedure of pulmonary vein isolation is not complete until the left atrial appendage has been addressed, which the left atrial appendage isolation can be performed either by stapler, clip device, or surgical ligation. The results of pulmonary vein isolation alone have been variable and have been dependent on the patient selection and the energy source used. So, subsequent studies that shown encouraging results in patients with paroxysmal atrial fibrillation. So, in patients with paroxysmal atrial fibrillation, some studies showed up to 82% freedom from atrial fibrillation at 6 months and 74% freedom from of antiarrhythmic drugs. Patient with long-standing persistent atrial fibrillation only had 70% incidence of normal sinus rhythm, with only 35% of patients were free from atrial fibrillation and antiarrhythmic drugs at 6 months follow-up. So, indication. Indication of surgical ablation for surgical treatment for atrial fibrillation can be divided in if the patient is going for other surgery. All symptomatic patient with documented atrial fibrillation undergoing other cardiac surgery procedure is indicated for surgical ablation procedure, and selected asymptomatic patient with atrial fibrillation undergoing cardiac surgery in which the ablation can be performed with minimal risk of experienced symptom. So indication for isolated atrial fibrillation surgery, standalone atrial fibrillation ablation should be considered for symptomatic patient with atrial fibrillation who either preferred surgical approach or have failed one or more attempts of catheter ablation or not a candidate for catheter ablation like patient with um, uh, left atrial thrombosis. There is a relative indication of patient to go for surgery for atrial fibrillation and lies in patients who develop contraindication to long-term anticoagulation with persistent atrial fibrillation and high risk for stroke. Patient with long-standing atrial fibrillation who had suffered who had already cardiovascular accident despite adequate anticoagulation. So finally, the surgical treatment of atrial fibrillation should be managed by a team approach, including electrophysiologist and surgeon. Thank you. Any question?
Thank you, Sultan. Anyone has question or comment?
I have one question. For the surgeries that are supposed to treat arrhythmia surgeries, do we have other than treat atrial fibrillation? Like, do we have surgeries that treat, like, for example, Wolff-Parkinson-White syndrome or other types of arrhythmia? Or do we only have Cox-Maze for atrial fibrillation, or the other surgeries for atrial fibrillation?
I think for that, in patients, usually they have good result in catheter ablation more than atrial fibrillation. That's why it's not well-established surgical treatment for these patients, because they have good result or acceptable result in catheter ablation.
So the only arrhythmia surgery that we have is as our surgical options to treat atrial fibrillation alone. We don't have other type procedures.
I think yes, but in general, all ventricular arrhythmias can be treated, but is not clear indication or they have good support to treat for surgery.
Thank you.
Sultan?
Faisal, معلش دكتورة بدي أقاطعك. Faisal, there is other type of arrhythmia you can treat it surgically, like atrial flutter. You can do same maze for the right side only. And sometimes if patient presented with large ventricular aneurysm and ventricular fibrillation, there is some type of surgery you can do to decrease the incidence of fibrillation by shaping the scar tissue and the ventricle.
Okay, great. Thank you very much.
Thank you, Hussein.
Sorry. Sorry.
Yeah, I just wanted to ask if we have a patient post-op and then developed atrial fibrillation, which is common, not controlled by medications, and they are symptomatic. So we can do something for them, or just medical, since they are post-op already.
I think the majority of people who develop post-op atrial fibrillation, they are responding well to medical treatment, and only few of them have persistent or can stay with persistent atrial fibrillation. For indication surgery for them or to consider alone, this patient, I think they develop atrial fibrillation in different way than the other patient who's like have micro circuit or foci from around pulmonary veins, or as we said, that we can do pulmonary vein isolation for them. But this is what I know. If anyone has
Dr. Ayat, thank you, Sultan. Again, what is your question?
Post-op patient develop atrial fibrillation, which is common, and he's symptomatic and not controlled by medications. Can we take them for surgery for atrial fibrillation, or we can do just medical management?
Post-op atrial fibrillation, according to the literature, it's ranging from 20 to 50%, depending on the type of the operation. And as Dr. Sultan said, the mechanism is totally different. So you treat them because many of them, they will return to normal sinus rhythm if they don't have the basis to have atrial fibrillation to start with. And you are assuming that the patient did cardiac surgery and postoperatively he developed atrial fibrillation, which is, as quoted in the literature, is 20 to, depend on what kind of operation, can reach to 50 or even 60%. And those patients, you treat them medically. Then, if they have the risk factor for to have atrial fibrillation, let's say they have very large atrium, they have develop tricuspid regurgitators, which will be leading to enlargement. At that time, you will follow the patient in the clinic, and if they met the indication for another surgery, this is different story, but you don't start even in the indication to treat atrial fibrillation. You can do ablation, catheter ablation for them, especially cases like patient post-CABG develop atrial flutter, and sometimes some types of atrial flutters, its success rates reaching around, yani, not 100%, but near 100%. And they can be treated via catheter, post-CABG, for example. Is this answer your question or not?
Clear, thank you.
دكتورة آيات
Yes.
as per guideline, there is no difference between type of atrial fibrillation. You go the same pathway, medical treatment, then catheter. If the patient met the criteria to go for surgery, he will go for surgery regardless, post-op or fresh patient.
Okay, thank you, guys.
You may want to consider a session of this with Dr. Rashdan. I mean, introducing the guideline as well as the clinical and practical aspect of it.
I didn't hear your question, Dr. Farid, clearly. Or
Well,
comments.
I was saying that I should consider maybe a session about arrhythmia surgery with Dr. Rashidan as well as the guidelines.
Yes, yes.
Sure. I'll try to get in touch with him and to arrange. Okay, we'll have a quick 5 minutes break and then we'll start with the journal club. Suha?
Yes, Doctor.
Can start.
Assalamu alaikum. Good afternoon, everyone. I'm Southbet R1 resident, and today, inshallah, we will have journal club about regroup trial, which is titled as randomized trial of endoscopic or open vein graft harvesting for coronary artery bypass. And I will talk about the short-term and intermediate follow-up. The short-term result was reported in 2018. Also, I included the most recent follow-up, which was reported last month. So as introduction, the saphenous vein graft is the most common conduit for CABG because of its ready availability and ease of use. So this study randomized patients undergoing CABG into vein harvested either endoscopically versus the traditional open approach. The scientific term of the regroup study was the safety signals that was reported in a study published in 2009 in 3,000 patients with a results showing a doubling of mortality in 18 months duration in patients receiving endoscopic harvest compared to open harvesting. And those investigators recommended a prospective randomized study, and the call was answered by the regroup trial. So the endoscopic vein harvesting is a minimal invasive technique designed to reduce the rate of harvest site complications, and it was first introduced clinically in the mid-1990s. It's currently being used in more than 90% of CABG cases in US, but however, in Europe, only 50% is being done with endoscopic techniques. So in this study, they were looking for an answer to the question that is the less invasive technique by endoscope in harvesting safe and effective with better clinical outcomes as the open technique in patients who are undergoing CABG. Coming to the study design, it's a randomized intention to treat multi-center trial where 3,394 participants were screened and 1,188 consented. And the actual enrolled number of 1,150 that were randomized to either endoscopic vein harvest or open harvest in 1-to-1 ratio. The actual study started at September 2013, and it was conducted in 16 Veterans Affairs Cardiac Surgery Centers in the States, with a median follow-up of 2.7 years for the short-term result and 4.7 for intermediate result. The plan was 14 years follow-up. So the inclusion criteria are the age of 18 years or older, and the patient who's undergoing elective or urgent CABG only with median sternotomy approach, and with at least one coronary bypass planned using saphenous vein graft for the conduit. And the experienced either endoscopic or open vein harvesters are available for the procedure. That means individuals who had performed more than 100 endoscopic vein harvesting cases and with the less than 5% conversion rate to the open harvesting. The exclusion criteria include combined valve procedure, moderate or severe valve disease, hemodynamically unstable or in cardiogenic shock, or those who enrolled in another therapeutic or interventional study, plus the off-pump CABG procedure, and those with limited life expectancy less than 1 year, or with history of lower extremities venous stripping or ligation, plus those who are unable to provide informed consent. The assessment was at baseline, during surgery, and after the surgery, at the discharge at 6 weeks, and every 3 months during the active follow-up phase. So moving to the outcomes, the primary outcomes was defined as the first occurrence of the major adverse cardiac events, which is a composite of death from any cause, non-fatal myocardial infarction, or repeat revascularization. And this is the primary endpoint of the study. A secondary outcome included major adverse cardiac events at 1 year after the surgery, additional secondary outcomes of major adverse cardiac events at 3 years after the surgery. Several tertiary outcomes were also assessed, including the severity of the incisional leg pain at the discharge and approximately 6 weeks after the surgery, and leg wounds were also evaluated. So the groups were balanced with regard to age, sex, smoking status, race or ethnic groups, body mass index, and other coexisting conditions. Here I can show you the baseline characteristics of patients was presented in the paper, and it's showing that the majority of the patients were in their 60s. Almost all patients, 99.5%, were male patients, and almost all patients in this study were overweight or obese, and almost 50% of patients are diabetic. The thing that I want to highlight here is that there was no significant difference between the groups. This table is showing the characteristics of the surgical procedure. So about 2/3 of patients were elective and 1/3 were urgent. And the majority of the patients were having 3 vessel disease, and 1/3 have left main disease. And almost all the patients have normal to moderate reduced ejection fraction. And all the patients have low STS score around 1%. And in the open technique, the vein harvesting time was longer with statistical significance. So when you compare the endoscopic versus open technique, you will have this result of primary outcome in short-term duration of major adverse cardiac events, which occurred in 15.5% in open harvesting versus 13.9% in endoscopic group, with no difference between the two groups in the term of hazard ratio, either primary or secondary outcome. For the tertiary outcome, the leg wound infections occurred in 3.1% in the open harvested group and 1.4% in the endoscopic harvested group with no statistical significance. This figure estimates the rates of survival and major adverse cardiac events during the entire follow-up. The primary outcome occurred in 21.9% in the endoscopic group versus 23.5% in open harvesting. And the death from any cause was 12% in the endoscopic and 13.2% in the open vein harvesting. The non-fatal myocardial infarction was 6.4% in the endoscopic compared to 7.3% in the open harvesting. And the repeat revascularization was 9.8% in the open versus 7.8% in the endoscopic vein harvesting. All these intermediate term result was with no statistical significance. So in conclusion, the trial did not show a significant difference between the endoscopic and open vein graft harvesting in the rate of major adverse cardiac events among patients undergoing CABG surgery during a follow-up period of median duration of 4.7 years. And the rate of wound complications was lower in the endoscopic harvest group than in the open harvest group. The trial was limited to experienced harvesters, so its results may not apply to other populations, plus the absence of the imaging evaluation of the graft patency. By this, I will reach the end of my presentation, but actually I have a question. If one of the seniors can answer it, I will, because one of the results shows discrepancy. I mean, here the no significant statistical difference it's showing with the leg wound affection, but in the conclusion it's saying that the rate of wound complication was lower in the endoscopic harvest group than the open harvest group. So can anyone comment on that or explain, please?
Assalamu alaikum. So, Suha, nice presentation. I received your invitation yesterday to be on the panel, but I also asked two other practicing surgeons, experienced practicing surgeons, to be with us on this topic. I asked Dr. Haytham Al-Bar and Dr. Hussein Al-Gattan to help us or help you define the usual point that we raise in a journal club. So if it's okay with you, we'll keep the answering your question till the end, because it probably will be answered during the discussion. If it's okay with you, we'll go ahead to Dr. Haytham Al-Bar, if you would like to take an opinion on this.
Sure, doctor, I will appreciate it. Thank you.
Thank you, Dr. Farid. Your question, Suha, was regarding if you go back to the figure for the wound infection. To start with, currently the trial was conducted, as you said, to know the safety for using endoscopic vein harvesting instead of using the open technique, because initially there was a concern even within the societies of the cardiac surgery regarding using endoscopic vein harvesting. And the conclusion, even from this trial and from the author of this, especially in this trial, is to have experienced surgeons or experienced surgical assistant to perform the endoscopic vein harvesting. There is multiple things can lead to graft failure. One of them is a harvesting technique, the endothelial injury, the use of suturing. They noticed, especially in the endoscopic vein harvesting, in many literature, in the literature review and the meta-analysis, that the use of endoscopic vein harvesting is associated with more use of repairing of the vein, which will affect the patency of the vein. But multiple studies, including this study, if you have a good vein harvesting by endoscopic technique by experienced personnel, that will lead to the same short plus mid-term result. However, keep in mind that the long-term result is still need to be followed, and that will shed the lights on the evidence or not the evidence, I mean the usefulness for the use of endoscopic vein harvesting. What I recall even from this study, there is no significant difference between the two groups in term of the wound infection and wound complication between the both group. However, it is not statistically there is no statistical difference, but it's less as numerical number with endoscopic vein harvesting. And even if you see in the graphs, a Kaplan-Meier, you can see that there is a point that the two endoscopic plus open technique, with the time, endoscopic will go more toward the harm points. If you go back, please, to the, not this one, another one. Yes, if you can see intermittent term result in this one, like death from any cause, start endoscopic vein harvesting to be more. There is a cross, what they call it, a points here, this one, and we need to see after that what will happen. Even the conclusion from this study and from the societies that the short term and the mid-term result, both, they can be used and there is no difference between both, and that will reflect the safety. And this is why this trial was initiated, to evaluate the safety of using endoscopic vein harvesting. But the most important things that you keep in your mind, which is the one you put it actually in your conclusion, that you need an experienced personnel to perform this.
Thank you, Haytham. Hussein, you have a take on the overall presentation and the design and the issues related to this article? Hello? Hello? I'm not sure if I'm connected, still connected. Can you all hear me?
Yes.
Okay. All right. So I'm not sure if Hussein is around, but anyway. So I'd like you, Suha, to comment on different aspects of this research and the article. Who was the sponsoring body for this study? Hello, Suha. Again, I'm not sure if I'm still connected.
Soha, open your mic, please.
Yes, doctor, sorry. I faced a problem with my mic.
Okay, so I had a question for you. In general, when you look at those articles, how do you look at the article and how do you interpret these results? At the end, would these results be interpreted enough for you to implement it in your practice or use it for your patients? So who's the sponsoring body for this study?
It's funded by Cooperative Studies Program, Office Research and Development.
Of which entity?
Of Veterans Affairs.
Okay, so it's a huge, let's say, non-profit organization that's basically similar to military hospital here, for example, looking at the outcome in their in those patients that can affect quite a huge sector of their patients. This will help you decide if, for example, the sponsoring body was a company that's interested to sell, for example, the endovascular instruments. That will be something for you to look and decide if there's any conflict of interest in that area. Or if you, for example, started the study because you have interest in the company, for example, or the stocks in that company. Those things that usually are not mentioned, but you should be aware of those issues. And the population distribution, did you look at the variation between the two groups? Was there any flaws in the design of the study?
Again, the population was randomized between the two groups, 1-to-1 ratio.
Okay. So though there was.
Dr. Farid is asking about the patient characteristics.
You mentioned it, so.
Yeah. Do you have that slide that shows the two groups of the patients? It's there in the article, I'm sure, and it shows basically there's very little difference between the two. But can you show us that graph? Okay, go ahead.
This one, yeah.
The basic characteristics of the patient baseline showed no difference.
Can you summarize, Dr. Soha, the characteristics of the population that were included in the study? So we can know if we can apply the result of this study on our population.
Sure. The characteristics, the baseline characteristics showed that the majority of the patients were in their 60s, and almost 99.5% were male 6, and almost most of the patients in the study were overweight or obese regarding the BMI, and almost like 50% was diabetic of the patient, but overall it's not showing a significant difference between the groups.
And go to the next slide, please.
Sorry, doctor?
Go to the next slide, please. Next slide.
Okay, doctor. And this table is showing the characteristics of the surgical procedure.
And also there is more definition of the characteristics of patient. As you said before, most of the patients here were having a normal ejection fraction to mild dysfunction, with ejection fraction of 54% plus minus 9. So we are talking about ejection fraction ranging between 45% to a normal ejection fraction. And almost all patients were low-risk patient, defined as an STS risk score of around 1. So
Yes.
these are basically the most important characteristics of the population included in this study.
Yes, obese, majority are men, that they are diabetics and low-risk patients. And this is important when you want to, yes.
So Dr.
Go ahead,
Soha, do you...
Continue, Haytham, please.
Yani this is what Dr. Murtada was highlighting is because when you want to apply any clinical trial or any evidence, you need to apply because on the same population. Is this population matching your population? The one they will benefit more even from endoscopic, and we saw, yani, we witnessed that in our practice, the obese patients, because with obesity, with diabetes, those patients, they will have higher incidence of wound infection because of their obesity plus because they are diabetics. So usually when you see the characteristic of the patient, because you want to match it the same. What?
Okay, Murtada, did you want to continue with your comment?
Yes, Dr. Soha, I think the most important what do you call it, problem with this population that almost all of the patients included were males. And what we notice in practice that the quality of the male veins is usually different from the quality of the female veins in terms of size and versatility. So this is one population of patients that is excluded from this study, and we cannot apply the result of the study for this gender of patient.
And something
Hussein?
important here, if we compare both groups, so it's randomization. So from this table, it's shown it's equal in both arms. So it's valid study. It's not necessarily applied to our patient, but there is at least no randomization bias in this table, because there is no difference between the two groups. I'm right?
The difference, Hussein, was in actually because the majority of the patients is like 90-something% they are male, not.
Yeah, I know, but in both groups.
Yeah, the randomization is okay, except for
But the design of the study may be flawed in that particular aspect, which is selecting the patient's population and how does it compare to our population, or if you want to extrapolate some of these data to our patients. By the same token,
sorry, go ahead. Sorry,
by the same token, I will go back to Suha. Is there anything else in the design that you may have looked at or thought of, in particular related to the technique?
Actually, Dr. No, I'm not sure. No.
Okay, so we'll go back now. I'll take a second round before I'll also elicit another point. We'll take another round among those experienced surgeons that we have on board on the panel. We'll start with Murtada first. Go ahead, Murtada, and then we'll go to the two practicing surgeons.
Yes, going back to Dr. Hussein's point, the randomization here is valid, and that is evident by the p-value, which is more than 0.5 between the two groups in all characteristics, and this is regarding the randomization. Another thing that almost all patients are low-risk patients with low STS, and this is one other characteristic that is differ from our usual patients, which usually have a little bit of a higher risk scoring. It usually, from what I see, it ranges between like 1 to 3%.
Okay, thank you, Murtada. Hussein?
The main follow-up in this study is it's 2 years. I think this is not enough to show the difference between the two techniques. And I noticed the one harvesting the vein endoscopically, it's let's say experienced surgeon, but I don't know to the other arm. They let the trainee to harvest the vein open or also experienced surgeon?
No, both.
No. It was one of the conditions. Yeah,
everybody should be experienced.
Yeah, one of the conditions to be of the operator is to be trained for at least 2 years in endoscopic techniques, and to have an experience of 100 cases or more, and to have a 5% conversion rate or less to be
this is
accepted
for
to be involved. No, for all patients, for all the trials.
Both are okay.
As well as the open technique. So thank you for raising those points, Hussein. We'll go to Haytham.
Both technique need to be experienced, and this is even was highlighted by one of the orthos in Cleveland Clinic, actually, one of the author of this trials, and he was emphasizing that this trial is to apply it on the patient on the same condition, meaning that the one who will perform endoscopic vein harvesting plus open vein harvesting need to be experienced. And he also emphasized that it is important when we want to code this study the result is only short term and mid term on the same condition. But your question, Dr. Farid, that if there is any difference in the technique, maybe I didn't notice if there is something that I miss it in the paper.
Well, it's a life experience actually. So I do, for example, valve preservation for the aortic valve with excellent arch surgery, and I think I do an excellent job there. But when it comes for Bental, I don't prefer to do the Bental, for example. So I can do it. Yes, I can do it. My preference is this kind of surgery, not that kind of surgery. And I'm sure if you looked into this group and related to the surgeon's preference or the surgeon's experience, you'll find some difference. For example, you'll find both of them are capable, have the capacity to do vein harvesting, and both of them have the capacity to do the open technique. But as a surgeon, in his preference, in his general practice, he will do the open technique. The other one, in his general practice, most of the time, day in, day out, he will do the intravascular technique. The surgeon's preference may make a difference in the outcome as well. You'll see that obvious in some of the numbers that they have mentioned. I'm not sure if it showed in the slides here, but they talk about leg wound problems somewhere in the range of 14%. If you take the experienced surgeon who do the endovascular and also have the preference for the endovascular from experience, from numbers, etc., they would have dropped that number down to maybe 5-7%. And the same applies to the open technique. The numbers are not different. They are still have the same 14% in general. But if you look at their preference, where they are expert in, where they are practicing and doing most of the time an open technique, they have less problems with the open technique. They may have more problems, just like it was mentioned earlier, suturing, repairing of the valves, or injury, or long-term. It may also reflect on the long-term patency of those valves. So if you look at those numbers, their problem, leg wound problem, drops from 14% down to, let's say, 5-7%. What I'm trying to say is that, yes, it's randomization, but randomization did not take an effect your own expertise and your own preference as a surgeon, which may affect the outcome as well. Actually, both numbers are a little bit high on the leg problems. Not too high, 14%. We in our institute, it's about 20% maybe. But if the more experienced places and practicing and preference, those numbers can be dropped significantly. Okay, I would like to go from here to another point, a second point. What is the main message that you would understand from this article? We'll start with Suha again. Suha, can you tell us what is the main message and how does it apply to your practice? Suha?
Yes.
So what is the main message you get from this article or this research paper or this trial, and how does it apply to your practice?
I think still we need to evaluate more to reach the point to have the same basic characteristics of our patients compared to the characteristics which mentioned in the study.
Okay, so by waiting, you can get more answers. And many times, by the way, we have uncertainty on life. Uncertainty. If you want to wait for the final answer, you may get some final answer after 1,000 years, but then it will be too late for me and you to benefit from that. With the current information that you have from this trial, from the recent update on this trial, how would this affect you? Hello?
Sorry, doctor, I didn't get the last point. I didn't hear.
Okay. So the message is that how would this article, with this research, with this paper, as well as with the update, the current information that you have, how will it affect your decision? Will you go with the endoscopic harvest, or would you not? What would you tell your patients? How would that change? Would you change your practice based on this?
No, still for me, it will not change
So
the
you'll
current
continue
practice.
with you'll continue with endovascular for life, right?
Yes.
Or open?
No, that open, I mean.
Okay. All right. Murtada, can you give us your insight in this?
Well, my take-home message from this trial that both open harvesting technique and endoscopic harvesting technique are both safe and effective if performed by an experienced performer. And if I'm going to, if I would like to implement the endoscopic technique in my center, I would first start by training my operators the same way they trained them in this trial, with a good training, and then having them start with the low risk cases like the population study and with the male patients. For a while, and then I'll monitor their outcomes, and afterward, if I'm satisfied with their outcomes and it is matching the results of the centers of excellence, like the results that happened with those patients, then I might implement this technique because of its acceptability within patients, and the other less important clinical aspects like cosmesis and the time for wound healing, for example.
And of course, you would also continue following up such research, knowing the fact if it may still affect the patency long term. So, Hussein, can you give us an insight?
I think from this study, both technique is valid and safe, but I'm not sure about the long-term result of endoscopic. So if it's my patient young, I will be hesitant to do an endoscopic vein harvesting. If it's female and obese woman, the risk of infection is higher, I may consider endoscopic harvesting, depend on the skills of the surgeon or surgical assistant harvesting the vein. So I will not apply it to all patients, but still I'm biased to the traditional technique because we don't have long-term result from any study to compare both of these techniques.
Okay. Any insight? Can you help us with that, Haytham? And maybe also if you can reflect on the opinion of Dr. Hussein and Dr. Fadal.
According to current evidence, this study and also in the literature out of this study, it's showing that endoscopic vein harvesting is safe, and there is other papers showing that the use of endoscopic vein harvesting will lead to less wound complication, wound dehiscence, plus patient satisfaction. Even in open technique to open the leg, all the legs, there is a different technique. Even in open technique to do skipping technique, that also been studied and showed less problem. Take home message is to go with endoscopic vein harvesting according to the current evidence in short and mid-term result, showing very good results in this regards, and there is no difference in MACE or myocardial infarction on short and long term and short and mid-term results in the literature currently. We need to follow after that. And the most important things, when you want to use endoscopic vein harvesting, you need to establish a program. I've worked with actually in two centers. Actually, they use endoscopic vein harvesting, and one of them actually they use the both technique, and clearly, I worked for one of them. They use actually the both two technique in duration of 6 months. I saw the wound infection in open technique, but this is biased. This is my observation. But I didn't saw any wound infection with endoscopic vein technique. Ambro with endoscopic, but with a condition that you have to have a program for it with experienced personnel. And also there is a very beautiful work was published by Dr. Afnan Al-Malki. I don't know if she's with us or not, with Dr. Ahmed Al-Arifi. They just published it maybe 1 or 2 months back regarding comparison between review articles or literature review about endoscopic versus open technique according to the recent literature. Even if she can give us some of what they found in their review.
If I may comment.
Are they with us on the group here today?
No, Afnan, she's with us. I mean, she's a resident in King Abdullah Medical City in Mecca. And they did a very nice, I will send it to the group, the publication with Dr. Ahmed Arifi, because he had a special interest in National Guard, and he started the program of endoscopic vein harvesting program there.
Okay, thank you, Haytham. Murtada, you had a comment?
Yes, actually, Dr. Haytham, your observation is supported by the latest European guidelines, which was published in 2018 regarding the use of endoscopic vein harvesting, where the writing committee reviewed all the important literature regarding this subject, and they recommended the use of endoscopic vein harvesting when done by an experienced surgeon in order to reduce the leg wound complication, and they gave it a class 2A recommendation. So with a level of evidence A, which is a strong recommendation, but still it's a class 2A, so you are free to use it or not use it.
Thank you, Murtada. I'd like here to interject that basically, I think the main message from this research is that for the midterm and for the short term, it's a safe procedure, and it's the safest when it's done by the experienced team. So I hate the notion that you would do it only occasionally for some patients. It's better to have a dedicated team that you would do it, and dedicated to programs like Haytham said, where you actually have all the resources available for that team, and they would do it day in and day out. And they have, of course, to have that preference to do it. So they will develop the experience along with the passion to perfect the technique. Suha, this was a nice topic to be chosen for this journal club. I hope to see more of these, Luay, and more like this kind of these discussion. Thank you for the panel that have served very well. Before we close, I want to ask Hussein if he has any final comments before we conclude and leave the mic to Luay.
I think the surgeon saw or work in an institute doing endoscopic, they are willing to adapt this technique. On the other hand, we don't use it. We use it infrequent, occasionally, as you said. So we struggle in the beginning for short duration, for long duration to harvest the vein. The quality of the vein wasn't good. So for that, I'm biased to the open technique. but from the literature, both is valid, and I like to see them long follow up. And now all the surgical subspecialty moving toward non-invasive. So if it's shown good result, it's good to decrease the incision size from the traditional to just small size in the leg. That will be more cosmetic.
Okay. Well, thank you very much, Hussein. I remind all the young generations that we have with us here today. Looks like we have 48 surgical residents and trainees, and maybe some consultants. That is, it's very good to have a passion regarding something, a technique or a disease or something that you would invest more and more time, read about it, perfect the technique, work on it, and develop your skills and develop your reputation. Talk to your colleagues about your results, show your results, show and tell, as they say in conferences everywhere. In this way, I think we will manage someday to advance the surgical part of our specialty. Mind you, Hussein, people have gone to the moon, and maybe they're on their way to Mars. They only do that with trying the new things and new ideas and perfecting them. Thank you all. Luay, you can take over. Thank you very much.
Thank you very much, Dr. Farid.
I just would like to weigh in this discussion before ending the session. And I'm looking at the practical point of view. Clearly, the endovascular technique needs longer learning curve, and so I don't think it's practical for the resident in particular. So how much time do you need to teach the resident to do it?
For this, okay, finish, then I want to comment. Sorry.
So if we have the evidence now that there's no difference between the both techniques, why I should change it? Because as you mentioned, that we need an experienced personnel, unless you have a dedicated program or dedicated person to do it, and also to give the chance for the resident to learn. I remember one day I was in a conference, and one of the world-class surgeons was asked why you don't use an endovascular technique. He said that because we have rotating residents, we cannot do that. That's my opinion. So for me, I wouldn't change my practice if we have an evidence that it is the same between both techniques.
Actually, the evidence is not the same. The evidence from this paper showing the safety endpoint, I send you the review articles because this is updated one, was done by our colleagues here. And if you read it, you will see the benefits of endoscopic. And as I said, it is important to be as a program. If you do it as a program, actually, I'm not expert in endoscopic. I did it. I didn't because I used to do because it's the same as laparoscopic. If you did before lab appendectomy or lab cholecystectomy, it is the same principle. You know, the same principle in endoscopic. And I use two devices actually, but I'm not expert because I don't have enough time to train myself on it. But I harvested the vein using endoscopic technique. It doesn't take that much time, and it's more fun. So to be honest with you, to do it endoscopic technique, I'm not sure we have Dr. Abir Al-Ghamdi, if she's with us. I would like to hear from her regarding her experience regarding endoscopic vein harvesting as a resident. Is she with us or not?
Haytham, can I comment?
Yes.
So yes, actually. So actually, Yes. From this trial, you can see that the time spent for harvesting is significant, statistically significant. Statistically, it takes less time to do the endovascular harvesting, and they didn't mention this specifically, but I think because of the time you need to close the wound will be much less with endoscopic technique. And going back to Dr. Luay's comment about the practicality of doing this, remember that all of us, inshallah, will be a consultant one day and will be performing the main procedure. So when we talk about this, we don't only take it as something to do ourselves, but something that we might implement in our center if we are in a position to implement it. The residents in Saudi Batin Center in Dammam, for example, I'm not really sure how much they see open techniques, but almost all cases they do it with endoscopic techniques. I'm not sure how much the resident is involved with this, but regardless, it's good if you are involved in it. But if you are not involved in it, it's good to know that if it's a good technique or not, in order to train your people later on to do it.
You need to push yourself, okay, to learn it. In surgery, you know that you need to push yourself. Yani I was lucky to have a group of people, and they teach me, and they were expert. It's the same like when you do, I mean the same principle, like lab chole, lab appendectomy. So it's really, I enjoy it when I did it the endoscopic way. But you just need to have someone or a team to teach you that. That's it.
Can I comment? I have two questions. Regarding the too much manipulation during endoscopy, I've seen this before in King Fahd Medical City, and there was really too much manipulation. This is the first comment. Second comment about, that's why I agree with Luay to continue in the open. And then the second thing is regarding how to convince the patient when you consent them and you tell them how you harvest the vein with an open technique, and other centers, they will do it endoscopically. So how come you are going to refer them for the endoscopic one?
I didn't get your question.
First question, what do you think about the manipulation during the endoscopic technique? Second question about convincing the patient regarding open versus endoscopic. They want to see only small wounds. They don't want to see open, big wounds.
Regarding the first question, there is a lot of manipulation, and they mentioned in the introduction, but that's not the standard. So they compare both group, and it shows same result. Even with that much of manipulation, the result is the same for 1 and 2 years. So it's depend on the one who's taking the vein. So maybe there are a lot of manipulation that reflect inexperienced one. But in general, the manipulation for endoscopic is more than the traditional one. But that's insignificant as a result from the study.
Dr. Hussein, the follow-up in the intermediate term was up to 4.7 years, and it showed the same results.
Still, Murtada, we need very long duration to judge on the vein patency, because it's 1 or 4 or 5 years. It's nothing.
The vein patency
yeah,
within
sure.
5 years, Dr. Hussein, what is the percentage of vein to be patent within 5 years? This is a different story. Nowadays, if you want to go through this argument, okay, nowadays they are shifting towards even arterial grafting. and to use arterial conduit, sorry. So even the 5 years follow-up showing that you have a good patency rates between both group, it's okay according to the current evidence. Both group, even in the literature, by the way, you will find that using of repairing the vein using proline is more in endoscopic vein harvesting in the literature. However, the endpoints, the midterm 5 years endpoint between both as a vein graft patency is the same, even when you use the when you repair the vein.
Yeah, but we are
And
not talking about technical issue, Haytham, here. We are talking about the internal injury.
Yeah.
So that's need long term to show the effect.
Long term, even in open technique, you know that in the open technique you have there is in open technique there is some methods which is not the optimal one. Let's say, I will not say the correct one. They manipulate the vein, they inject the vein with a saline, with a high pressure, and that will lead to endothelial injury. And there is no touch technique in the vein itself when harvesting in the open technique. And currently in the literature there is talking about no touch technique even in endoscopic vein harvesting, and there is a special technique to do that in endoscopic. I'm just highlighting to you because I saw in 3 centers endoscopic vein harvesting.
By the way, they are inflating the vein in this study or not?
I don't know. We need to go to the supplement. I didn't read the supplement about this one. But you can see the literature review. I mean the review article. I just sent it to the group. All the details that in your mind, with Dr. Ayad, Dr. Muhammad Al-Khalaf also, you can read all about all these concerns that have been raised today.
Luay, how do you convince your patient when they come to the clinic and ask you why you don't refer me for the endoscopic one and you prefer the open in your center, since your center is doing this?
I have never been asked that question. Maybe the patient are not aware about both techniques, but for me, my rationale that this technique has been there since many years and has been proven. This is a relatively new technique. So
what sorry
Luay. خليني أكمل بس وبعدين. I would say that both techniques have the almost same result in terms of at least up to the current evidence have the same result and same risk of infection. And if they are willing and glad they are still convinced about the endovascular, I would ask them to go to another center.
Okay.
No, the same. According to the current evidence, you have less infection, actually, with endoscopic vein harvesting, and the same MACE and the same outcome in comparing open versus endoscopic.
I think, moreover, I think there is the imaging of the vein before harvesting, and if the vein is harvestable endoscopically or no, is very important to harvest the vein endoscopically. I think that all the surgical field is going to the minimal invasive and robotic and endoscopic procedure. I think it's safe and it's valid, and we need the long-term result. And for sure, the experience of the performance is very important.
In this, were they able to control for the management of patients the guideline-directed medical therapy, risk factor control, or did they control for the technique, the surgery? Because I remember follow-up time was up to 2 years. And up to that duration, it's not technique, it's the patient post-operative. When it comes to the conduit patency.
فيصل صوتك يقطع, we cannot hear you.
To hear me now?
Yes.
Yes. I was asking, this they reached up to 6 years of regarding their primary and tertiary outcomes. Regarding myocardial infarction, which is related to were they able to control for the medical treatments? Like, were they following up with the guideline-directed medical therapy also for the risk factor control, or only they were controlling the surgical techniques only? Different aspects when it comes to long-term patency.
I'm not sure, but it should be applied to both groups.
Because they didn't it with the patients following up with their medication, did they control their risk factors? Operatively, were the blood glucose controlled? Because this could affect the the chance of having wound infection and also term graft patency. And also in the kinetics, they mentioned 2 devices used to for harvesting, and most of the patients, 90%, were from this device. So that would reduce the visibility of this.
Anything done should be done in both groups equally. So even if they don't follow the risk factor or modify the risk factor or follow the guideline-directed medical therapy, it should be for both groups. So the randomization valid here.
Yeah, but they did not mention it. I can see the mean blood glucose read 10 operatively, for example. If they did well control the blood glucose level properly, they should have mentioned at least the mean between. I think that would be more helpful and make us make a decision at least that they are both techniques.
Okay, thank you everyone for this nice discussion. So we'll have a break for 10 minutes and then we'll come back. Ahmed.
Yes, Louis.
تفضل.
Thank you, Louis. Assalamu alaikum. Good afternoon, everyone. I know it's been a long day and it's Thursday. I enjoyed the previous two presentations. Thanks to Sultan and thanks to Dr. Suha, and for the active discussion that has been ongoing. So today we will discuss a Momentum 3 trial. It's basically 3 stages trials that has been done. First with the rematch trial that started to prove that the pulsatile left ventricular assist device compared to optimal medical therapy, where pulsatile Lvad has been shown to be superior to medical therapy. And then in Heartmate 2, they replaced they compared the pulsatile Lvad with the continuous flow Lvad, where continuous flow Lvad showed better and superior result. And at the end, in the Momentum 3 trial, that they compared the Heartmate to the axial flow pump with the centrifugal flow pump as both of continuous flow pump, where Heartmate 3 showed superior result. So beginning with rematch trial, the question was, in patient with end-stage heart failure, does destination Lvad therapy reduce all-cause mortality as compared to optimal medical therapy? The bottom line was the Lvad therapy reduces all-cause mortality as compared to optimal medical therapy. In the study, they aimed to determine the suitability of the Lvad for destination therapy. The pulsatile flow Lvad Heartmate versus optimal medical therapy, and their primary endpoint were to investigate the all-cause mortality between both groups. The inclusion were the NYHA class 4 with left ventricular ejection fraction of less than or equal to 25%, who were ineligible for cardiac transplantation as a bridge or destination therapy. And the group number were in Lvad 68 participants, and in continued optimal medical therapy 61 participants. So they found that the Lvad implantation was associated with 48% reduction in mortality as compared with optimal medical therapy with significant p-value. The survival at 1 year in the Lvad group was 52% as compared to 25% in the optimal medical therapy with significant p-value. At 2 years, 23% and 8% in Lvad and optimal medical therapy group respectively were the number of survival. Incidence of serious adverse events was higher in the Lvad group than in the optimal medical therapy group. Rate ratio were 2.35, and I assume that it is because the number of mortality in the optimal medical therapy and the longer follow-up of those survival of Lvad that showed this incidence of serious adverse event. So this is in regards of rematch that we proved that the Heartmate is better than optimal medical therapy on those heart failure patients who are ineligible for heart transplantation. In Heartmate 2, the clinical question was, in patient with advanced heart failure, do continuous flow left ventricular assist devices improve survival free from disabling stroke and device failure as compared with the pulsatile devices? So the bottom line was continuous flow Lvad improved survival free from disabling stroke and device failure as compared with pulsatile devices. And the rematch and interpret trial, they've been already, as we said, investigate the feasibility of the LVAD in general. And the LVAD used in these studies were pulsatile flow devices with a larger size and less durability as compared to new continuous flow LVAD. Heartmate 2 study is to investigate continuous flow LVAD compared to pulsatile flow, and the primary endpoint of 2-year survival free from disabling stroke and LVAD failure. So the inclusion was NYHA class 3 or 4, left ventricular ejection fraction of less than or equal to 25%, treated with optimal medical therapy who were ineligible for heart transplant. Randomized to receive continuous LVAD, 134 participants, or pulsatile flow LVAD, 66 participants. And the continuous flow LVAD was associated with increased probability of 2-year survival free from disabling stroke and LVAD failure, 46% versus 11% in pulsatile LVAD group, with a hazard ratio of 0.38 and with significant p-value from the freedom from disabling stroke and failure. Continuous flow LVAD was also associated with significantly less major adverse events, and the rate of hospitalization was also significantly reduced. So by this, we came to know that continuous flow LVADs are better than the pulsatile flow LVAD, and in turn, as a rematch study, that it is also superior to optimal medical therapy alone. Here in Momental trial, which is Heartmate 3, the clinical question was, in patients with advanced heart failure refractory to medical management referred for durable left ventricular assist device placement, is a magnetically levitated centrifugal flow device superior to an axial flow device with regard to reoperation for device malfunction or disabling stroke. The major points here that I want to highlight that LVADs are proven effective, as mentioned in the previous studies. Transition from first generation pulsatile flow devices to second generation continuous flow devices associated with fewer mechanical failures and disabling strokes. Magnetically levitated centrifugal flow devices may improve upon the earlier axial flow design by using a magnetic induction motor to generate flow centrifugally. Momentum 3 trial randomized 1,028 patients with advanced heart failure requiring LVAD for either a bridge or destination therapy. Left ventricular ejection fraction of less than or equal to 25% with NYHA class 3 or 4, along with inotrope dependent or cardiac index patients of less than 2.2. The Heartmate 3 centrifugal flow LVAD versus second generation axial flow LVAD. So the design is here for Heartmate 3. It's a multi-center study with open label, randomized control trial. So they randomly assigned 2 groups. It is open label that both the investigators and the patients are not blinded to the treatment being provided to them. And we will discuss about this issue and the introduction of bias in such studies. And the number is, as we mentioned, 1,020 patients, Heartmate 3 with centrifugal flow LVAD group 516 patients, and Heartmate 2 axial flow LVAD 512 patients. The setting were in 69 sites in the in US centers. Enrollment were from September 2014 through August 2016, over 2 years. duration of follow-up. Analysis was intention to treat, so the results were analyzed as intention to treat analysis. Primary outcome were reoperation for device malfunction or disabling stroke. The inclusion criteria for the population: age more than or equal to 18 years, body surface area of more than or equal to 1.2 meters square, and NYHA class 3 to 4, left ventricular ejection fraction less than or equal 25%, and advanced heart failure defined as either of inotrope dependent patients or a cardiac index of less than 2.2 without inotropes, and either of on optimal medical therapy for at least 45 out of 60 days, advanced heart failure for at least 14 days, and dependent on intra-aortic balloon pump for at least 7 days. Exclusion criteria, where etiology of heart failure is uncorrected, technical factors that prohibit using of the Lvad, existing durable mechanical circulatory support device prior to implantation, pregnant patients, mechanical aortic valve in position, a history of organ transplantation, platelet count of less than 100,000, psychiatric disease or disorder that a role would leave the patient with non-compliance to medical management, a history of confirmed untreated abdominal aortic aneurysm of more than 5 centimeters in diameter within 6 months, active uncontrolled infection, intolerance to anticoagulant or antiplatelet medications, presence of severe end organ dysfunction or failure, moderate or severe aortic insufficiency without plans for correction during Lvad placement, pre-albumin level of less than 150 milligram per liter or albumin level of less than 30 gram per liter as a malnourished patient. They also included to the exclusion criteria planned biventricular ventricular assist device implantation candidates, known hypo or hypercoagulable state, predicted survival of less than 24 months outside of heart failure. So if the patient is having a secondary diagnosis, that is really affecting the patient's survival. So here, maybe it's a long list that it is not very well clear, but I can assure you that the baseline characteristics for the both arm groups of the centrifugal flow pump as a continuous flow pump versus axial flow pump group they are the same with no difference. The mean age were around 60. Otherwise the male patient number was considerably higher than the female participants, and the others are all within there was no significant difference between two groups. The intervention that has been carried, patients randomized as a 1-to-1 ratio to either Heartmate 3 or Heartmate 2. The Heartmate 3, as we mentioned, 516 patients. Heartmate 2 is 512 patients. The randomization performed with the use of permuted blocks, stratification by study center. Because it has been done in 69 centers in US. Data collected at 1 day, 1 week discharge, and 1 month, 3 months, then every 6 months until 2 years. The recommended antithrombotic management in both groups included aspirin 81 milligram to 320 milligram once daily, and warfarin for targeted INR of 2 to 3. NYHA classification and 6-minute walk test performed by a trained technician used to assess functional status. The primary endpoint assessed as intention to treat, but all secondary endpoints assessed as per protocol. According to what patient has received during the study. The primary outcome that we found on this and the Momentum 3 trial at 2 years, that 397 patients, that is 76.9% of the participant versus 64.8% survival at 2 years. And this is clearly showing a non-inferiority criterion that Heartmate 3 is non-inferior to Heartmate 2. So continuous flow pump were proven that it is not inferior to the axial flow pump. And the superiority criterion also, they found that the patients with Heartmate 3 were superior in their results compared to the Heartmate 2 axial flow pump. The principal secondary endpoint of pump replacement at 2 years occurred less frequently in the centrifugal flow pump group than in the axial flow pump group. 12 patients, 2.3% at the Heartmate 3 versus 11.3%, 57 patients in the axial flow pump Heartmate 2. And this is also significant in favor of Heartmate 3 device. Here we can see the primary and principal secondary endpoint between the centrifugal flow pump group and axial flow group, and by all assessment and the outcome that's been found, that the centrifugal flow pump were superior to axial flow pump. As we see here, the numbers between the withdrawal before implantation, withdrawal after implantation, underwent reoperation to replace or remove the pump, had disabling stroke, died within 24 months after implants. The number of the patients are more in the axial flow group. Here we can see the Kaplan-Meier estimates of the primary endpoint and the intention to treat population. As we can see, the centrifugal flow pump at initiation of the study, 516 patients compared to 512 patients at the beginning of the randomization. We can see over period of follow-up of 2 years, we can see the diversion of the group of axial flow pump that is reaching at 2 years of 60% compared to 70% and the continuous flow pump. And this is clearly, we can see here that almost a difference of 50 patients has been survived in the group of centrifugal pump over the period of 2 years. And this can show us, we can predict that with longer follow-up, after seeing this, and we can read it, there will be more loss of patient due to strokes or mortality in the axial flow pump compared to the centrifugal flow pump curve. The most common causes of death among the patients with either device, according to their analysis, were right heart failure, stroke, and infection. And I just brought this just to keep in mind when those patients, infection should be really taken seriously. So the stroke, if happened, we must exercise the highest standard of care to prevent such an event, with either optimal follow-up of anticoagulation with patient on Lvad implants, and the right heart failure with optimal medical therapy while after implantation. In the subgroup analysis, there was no significant interaction between groups with regard to the primary endpoint that was observed for the prescribed subgroups according to the age, sex, race, or ethnic group, intended goal of device therapy, or intermax profile. The criticism that I can draw from this study that it is open label design. It allows for bias and outcomes assessment, as the both patient and the caregivers they know what kind of the treatment that the patient is gonna receive, and the patients themselves, they know what kind of device they are receiving. And this may, which in particular important with a clinical driven outcome, that example reoperation, giving the follow-up or during the study period. If I knew that if there are patients in the axial flow pump group have higher stroke or higher whatever complication compared to the Heartmate 3, then I would definitely be having low threshold to go for reoperation in Heartmate 2. And this might introduce bias, but the effect of this bias is likely modest if present, giving the data shown in the study. Second point, given only 2-year follow-up period, the effect of possible longer-term complications of the third generation device, example, outflow, a graft twist, or electrical failure, which have been described, cannot assist with certainty in this study. The funding that has fund the research supported by Abbott, the maker of both Lvad models studies, the Heartmate 2 and Heartmate 3, authors with multiple ties to industry, including study sponsor. Sponsor provided devices, studied and performed data analysis with verification by an independent statistician. So I'm not sure if this is really will change our understanding or how we will interpret the result that has been shown, as it is was funded by the same funding company. But the reassuring point is that both devices were produced by the same company that has funded the research. Here, finally, we can see the principal safety outcomes in the per protocol population. In terms of the suspected or confirmed pump thrombosis, the study were in favor of centrifugal flow pump. In any risk, any stroke, like disabling stroke, there was both in favor of Heartmate 3. Any bleeding, gastrointestinal bleeding, also in favor of Heartmate 3, and the remaining were not in favor of any of Heartmate 3 or Heartmate 2. But according to the details mentioned in the paper, that this is a relative risk of 95% confidence interval. But if we shift it to 90% confidence interval, those all points will be in favor of Heartmate 3. Here is a small video about the one of the principal investigator, Dr. Mehra, that is speaking after the presentation of this study in American College of Cardiology.
I'm Peter Block here at ACC 2019 in New Orleans, and with me is Mandeep Mehra. And we have just heard about the momentum trial. Now, Mandeep, you've talked about momentum with me before. We've been through a number of iterations of this technology, and now we have momentum 3, which clearly now has shown that the technology has made a quantum leap forward. So tell me about the trial quickly, and then let's talk a little bit about how these patients are faring.
Yeah. So Momentum 3 is the largest trial in advanced heart failure of left ventricular assist device therapy. It's a one-to-one randomized trial of a device called the Heartmate 2 device compared to the new device, the Heartmate 3 pump. The Heartmate 3 pump is a novel technology. It's a unique pump designed with a fully magnetically levitated rotor, and it makes it frictionless. The pump is much more forgiving on shear stress.
Yeah, that's what I was going to ask. Clearly decreases shear stress.
Clearly. And we also added a pulsatility component into the pump. So the pump pulsates by revving itself up and down.
You're making Mother Nature envious.
We're trying to mimic the biology as close as we possibly can. So this trial was really done to test this new left ventricular assist device because we have improved survival in patients with left ventricular assist devices, but at the cost of a number of terrible complications along the way.
Yeah, thrombosis, hemostatic events, basically.
Really,
stroke. And all those bad things that happens when you have
things that stop clinicians from advancing the referral base for these patients.
There you go. So tell me what Momentum 3 has shown.
Yeah, so the 1,000 final report on these patients has shown that the Heartmate 3 pump with this novel technology is clearly superior to the older Heartmate 2 pump. How is it superior? If you quantify the net clinical benefit, for every 10 patients in whom we choose to place the Heartmate 3 pump, we avert 2.2 pump clotting events or pump thrombosis events, 2 strokes, and 6.8 major bleeds, of which about 4 of them are gastrointestinal bleeds. So it has a number needed to treat of less than 1.
I mean, that's crazy, right? It is that much better. So is Heartmate 2 going to continue to be manufactured, or is the company just going to move on and say, this is crazy, the results are so good?
Well, I think the results are so good that it is going to be crazy to de novo implant a Heartmate 2 over the Heartmate 3 if you had a choice. If you don't have a choice, or if you need to replace a Heartmate 2 with a Heartmate 2, then you may still need a few Heartmate 2 devices on shelf. But I don't see any choice but to pick the Heartmate 3.
You know, we were talking earlier about these patients and their thrombotic events and such. And the fact is, though, the mortality overall at what, 2 years?
At 2 years.
Is no difference between the two machines. So I was so impressed that we have come, the people who take care of these patients have come so far in dealing with their hemostatic thrombotic events.
Yeah, absolutely.
It's
It's a great point. 81% survival at 2 years in these patients, and now a much more forgiving survival.
So you said earlier, they suffer, but they suffer from different things.
Yes,
right?
Exactly.
So in fact, their strokes go away. Their thrombosis issues go away.
And bleeding.
And their bleeding goes away. And, this is all a huge step forward technology-wise. Thank you so much, Mandy.
Thank you, Peter.
So overall assessment of Heartmate 3 trial, first question comes to my mind. How important is the paper to me? It is very important, and it is really showing a very excellent result for heart failure patient once they reached very low ejection fraction and those with maximum medical therapy. So it is open for anyone if anyone want to comment on how important is the paper. Maybe Dr. Loy, you can comment, or Dr. Al-Hudayb.
It's important, at least for us, as we see in King Faisal, we see a lot of these patients, as we have a program for that patients. So it is important to be up.
You sound so far away.
Is it better now?
Yeah.
Yeah, as I said, it is important, at least for us in King Faisal, because we see a lot of these patients because we have a program for Lvad, so it is important to be up to date.
So I agree with you that we see a lot of not a lot of the patients, but quite good number of Lvad implant patients who are waiting for heart transplant or destination therapy. The next question that what impact will it have on the field of cardiac surgery or in heart failure programs? So I think the impact is huge to find such device that can improve survival of the patient and improve their quality of life. That has been investigated in this study, and it's been quite a good result in terms of the quality of life and freedom and the survival, and that can pay time for the patients to be on waiting list for heart transplantation. And even though that I read some reports that some of the patients who are young with quite better ejection fraction that has implanted with Heartmate 3, that they can put it as bridge to recovery, and then the device can be removed. But this is beyond the scope of this journal club. So it really does have a huge impact on the field. The third question, would you cite it for future research or improvement in the same category of the patients? Yes, I would definitely cite Momentum 3 trial from my own perspective. And for the fourth question, would you base your own future experiments on these findings? Yes, but I think that here in the kingdom, we are still does not have the enough researchers in our patients and our population that we can implement or started new experiments or to conduct clinical trials at the moment. So I think here I reached my end of presenting the Momentum 3 trial study. Thank you all. If you have questions or points to highlight or comment, please, I would leave it to Dr. Loy to moderate the discussion.
Dr. Farid, do you have any comment?
Actually, this is a very nice review, and it tackles many points that we expect in the genre club. It's always better to have some expert in the field with you maybe one of the consultants, and we have quite few between Riyadh and the Eastern Province and the Western area that have quite a bit of experience in this era. So maybe next time when you choose an article like this, it's also better to supplement that with an expert opinion. Thank you very much, Mohammed. I think that was a good presentation.
Thank you, Dr. Khogir. And definitely I will consider a second time to bring expertise from the field.
Thank you, guys. I enjoy the discussions really.
Okay, thank you, Mohammed, for the presentation, and thank for Suha and Sultan, and for Dr. Farid and Haytham Hussein for this great discussion today. And see you next week, inshallah.